Welcome to our podcast, Neurology Morning Commute, New and Emerging Treatments for ALS. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Mitsubishi Tanabe Pharma America. In this podcast, Dr. Jeremy Scheffner and Dr. James Berry discuss new and emerging treatments for ALS, as well as managing some of the more debilitating symptoms of the disease. Information about the faculty and disclosures can be found at morningcommutepodcast.com/ALS. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Scheffner is a professor and chair of neurology in the Department of Neurology at the Barrow Neurological Institute in Phoenix, Arizona. Dr. Berry is the Winthrop Scholar in ALS Sciences, the Averill Healy Endowed Chair in ALS, and the chief of the MGH Division of ALS and Motor Neuron Diseases in the Department of Neurology at Massachusetts General Hospital in Boston. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Scheffner will begin our discussion.
Hello, everybody. Welcome to our podcast on new and emerging ALS treatments. James, thanks for joining me today. I kind of want to start with saying that this kind of discussion really couldn't have been done 20 years ago. At that point, when I was younger in my career and James hadn't even started yet, really the number of treatments that people talked about and thought about as efficacious in either disease modification or symptom management would never have come to mind when we didn't really have the ability to think about those things. And so even though ALS remains an incompletely treated disease and we clearly are motivated to find new and better treatments, the fact that we can talk about many things to do for patients with ALS, I think, is a positive step. So let's start by talking about where we are. We're going to go a little bit in chronological order and start with the first drug that was approved for symptom management for disease modification in ALS, and that's riluzole. James, how do you use riluzole?
Yeah, I think riluzole is sort of the first crack at the disease. And I guess one of the things to say about riluzole is that there's a big difference between having nothing and having something. And so, riluzole is something I talk about with every patient. And certainly the majority of patients, I think, elect to use riluzole. We think about it as a disease-modifying therapy that has a modest effect, I think. I think we all kind of agree in the field that the effect is modest, but it seems to be there, demonstrated again and again, both in the initial trials as well as in sort of follow-up, more real-world evidence or retrospective trials, studies.
Yeah, I think that riluzole sort of came into use without a clear understanding of how beneficial it was. The original studies, the first one, which was fairly small, suggested a quite significant effect, and the second, much larger study, suggested a more modest survival effect. But there have been a lot of studies since then, a lot of studies in countries where healthcare systems went from everybody having riluzole unavailable to everybody with ALS having riluzole available. And those kinds of studies have really suggested that the survival benefit, which was estimated at about 3 months in the second phase 3 study, actually may be significantly greater than that. And there also is some hint, both from the original riluzole study, which had some functional measures, as well as some of the studies investigating other agents where riluzole was either taken or not taken at the decision of the patient, to suggest that there is a functional benefit as well. So I too suggest it for everybody. It's pretty well tolerated. The only adverse effect that I see with any regularity is our GI symptoms. And I tend to, when that happens, suggest that instead of taking it as the label directs on an empty stomach, to have patients take it with meals. Do you do that as well?
I do. And, I would say, I think it's about 10% of people at the most who have these GI effects. We don't want people to have nausea because we might talk about it later, but one of the really important things as far as nutrition is just making sure that people with ALS maintain their weight. I guess one of the things I do is if people have nausea, it often happens right when they're starting the medication. I might have them stop the medication and then, stop for a few days till it goes away, start at a lower dose and see if they can tolerate that, and then move up after a couple of weeks to the full dose. So they might go to once a day for a couple of weeks and then twice a day until they can tolerate that.
I've had success with that as well. I do worry about blood levels being somewhat lower if people take the drug with meals, but actually it turns out that the blood levels with riluzole are incredibly variable, whether it's taken with an empty stomach or a full stomach. So, there isn't that much of a systematic change. Yeah, so I agree with you. I think it's a modestly effective drug, but it changed the way people thought about things, in that all of a sudden people had a drug to give to people with ALS and could say with some confidence that, this drug had a meaningful benefit for people who took it. So, and it's still part of any kind of treatment regimen that I prescribe. But a long time went between 1995, when riluzole was approved, and 2017, when the next drug was approved, and that's edaravone. And although there was significant discussion about whether riluzole should be approved, many years later, there was also significant discussion about whether edaravone was meaningful in terms of helping ALS patients and should be approved. James, do you want to sort of describe the early studies?
Yeah, and I should say that, I think, I wasn't yet in the field when the riluzole trials were sort of coming out and that data was coming out, and it'd be interesting to, I'll describe the studies in edaravone. It'd be interesting to hear how the debate was similar and different when edaravone first came out. So there were two really seminal studies, phase 3 studies, looking at edaravone. In the first study, both were done in Japan, but in the first study, there were around 200 participants, and there was actually not a significant difference between the rate of disease progression in people who were taking edaravone and people who were taking placebo. But when the investigators looked at subgroups, they found that those who had a more rapid disease progression did have a larger difference numerically between the rate of progression on placebo and the rate of progression on edaravone. This was a relatively short study, 6-month study. And so, I think there were some questions about whether the slowest progressors in the study were not contributing meaningfully to the data. You can't show slowing of a disease if it's not changing over time. And so that was one of the reasonings, that and the observation that in the more rapid progressing group, there looked like there was a numerical difference. But the investigators went back and did a second study, which was actually a little bit smaller, but a more highly selected, more homogeneous population. So there were just over 120 participants in the second study. And in that study, there was, and actually in that second study, everybody was on riluzole as well, just to reduce the heterogeneity of the trial population. And in that study, looking at the ALS functional rating scale, which is a 12-item questionnaire and how we assign the primary endpoint in a lot of our trials, there was about a 30% slowing. Now, over 6 months, that meant about a 7.5-point drop in the placebo group, about a 5-point drop in the treatment group. But again, that amounts to about a 30% slowing, which was highly significant.
Yeah, that brings up the question of how we measure disease progression in ALS currently. And the ALS Functional Rating Scale revised is the most common primary outcome measure in ALS trials. It's received a lot of somewhat negative attention lately, in the sense that people realize that each question has not the same amount of, first, importance to ALS patients and second, granularity. But it's been used enough now that we really do understand how it behaves, and really it's proved reproducible quite well in terms of when trials recruit the same kinds of patients, we see the same rate of decline in the ALS Functional Rating Scale. One of the weaknesses of this, as well as any other scale really, is that when you say there's a 2.5-point change between placebo and treatment groups, it's not necessarily immediately obvious what that means to a patient. And so oftentimes what I'll end up doing is going over the individual items of the scale. For example, there's a walking question or a speech question or a swallowing question. And it turns out that if you look at the items, each one of which are graded from 0 to no function to 4 to normal, which is normal function, a single point drop in some of these in some of these questions is really very important to a patient. It's the difference between being able to eat or not, or
Right.
being able to walk or not. And so a 2.5-point change, although it may sound like not a lot, and it may be different from person to person because it depends on which 2.5 points have changed, in general is a quite significant alteration in the function of people with ALS. So to me, this was a pretty robust finding.
Yeah. And it was highly statistically significant. The other thing I would say is that it really demonstrated how we can design clinical trials in a really responsible way, which was that there was one trial that did not have an overall benefit, but there was a subgroup that looked like they may have derived more benefit. And then the second trial was designed based on that prospectively, and that's where the significant benefit came from. So I think that's the way that we should be doing trials is gleaning all the information we can from them and then doing more prospective trials to test our hypothesis.
Yeah, and I completely agree. I mean, so, the fact that the first study you discussed didn't show a significant difference is somehow, in some people's thoughts, taken as a weakness in this developmental program. But I think it's actually a strength. I mean, they looked at the group of patients in whom they saw the strongest effect and designed a study to test the hypothesis in that group and saw a significant signal. That first, actually, both studies were short. They were 6 months, and they were basically enrolling people with relatively early ALS. And so within 6 months, there was very little of a survival signal, meaning that really everybody just about survived the placebo-controlled portion of this trial. I know you've been involved in looking at survival changes as a function of edaravone in sort of real-world subsequent data. Can you talk about that a bit?
Yeah, so there was a poster at the European ALS meeting, the annual European ALS network meeting this year that was looking at, in a large insurance database, the effect of edaravone usage in people with ALS. And, using propensity score matching and looking at real world evidence in this, very large database. And, the results of this was that using really robust matching methodology, looking at people who are not on edaravone and compared to those who went on edaravone in 2017. So we have sort of a seminal time when people could choose to either go on or not go on, and we can get good cases and controls. There was a 12-month survival difference between those who did not use edaravone and those who did use edaravone. I think that's it's certainly the largest study that's looked at this, and I think it's a different methodology than clinical trials, but it's the kind of evidence that we saw coming out, after the initial randomized trials in riluzole as well, that I think began to kind of build the evidence that it wasn't just 2 trials, but it was 2 trials plus, lots of experience and lots of other additional different kinds of real world evidence about riluzole that began to kind of build a body of evidence to support its use. And I think we're beginning to maybe see that in edaravone as well.
Yeah, I think so as well. And I mean, you had mentioned, that maybe to talk a bit about sort of the controversies in terms of physicians adopting riluzole when it was first available, and then with edaravone. I am old enough to have experienced both, and the issue with riluzole really was fighting the kind of therapeutic nihilism that had emerged around ALS. It was thought to be a neurodegenerative disease that was impossible to deal with, and all you could do is sort of, bring people to terms with it. And the idea that you could actually do something to impact the course of ALS was a huge leap for many people who had been working in the field for years and years. The second issue was that the very large phase 3 survival study showed a difference in survival in the sort of early term to middle stages of the trial. This trial was an 18-month trial. And at 12 months, there was a significant survival advantage in people taking riluzole. That difference got less and less as the trial got longer. That's actually, I think, to be expected in survival trials where you're not actually curing people. So I think it was more a statistical phenomenon than a real phenomenon, but that was a reason for people to not judge riluzole as significant as I think it was. For edaravone, there was a lot of talk about how strictly the trial was enrolled in terms of what the inclusion criteria were. And I think at least I hope, that there's been some education in that regard as well, that restricting patient characteristics in clinical trials is a tool to make trials more efficient and shorter, not to necessarily predict that those are the only people who will benefit by a drug.
Yeah, I think that's right. I mean, if you use the enrollment criteria to choose a biologically different group of people than the overall group of people, then then maybe generalizability becomes a problem. But in ALS, we see a lot of clinical heterogeneity that is, we don't think that there's a biological underpinning for. And we're also probably reading across some biological heterogeneity, either across times within the disease or, but if we see effective therapies in the group of ALS as a whole, then we think that we can generalize. So I agree.
So in terms of drugs approved for the treatment of ALS writ large, we've sort of come to the end. But there are a couple of other ALS treatments that have data associated with them that are not approved at this point that I think are important to talk to. And then I'd also like to spend a few minutes talking about how we treat ALS symptoms. First, let's talk about a drug developed by Amylyx called AMX0035. This is a drug that had really its first human exposure in an ALS trial that was almost exactly the same size as the pivotal edaravone study, and actually showed very similar results. James, do you want to summarize that briefly?
Yeah. So again, it was just over 120 people enrolled in this study. There was a similar move to find participants who had at least not the most slowly progressive forms of ALS, because again, it was a 6-month trial, and also to reduce heterogeneity by having inclusion criteria that would get us sort of at least semi-similar participants. And those were really the same principles that were brought to the edaravone, the second edaravone trial. And then, the results of the AMX0035 trial were that we saw about a 25% slowing of progression on the ALS-FRSR. So really, really similar kinds of results from a similar design trial, which is really exciting.
And this study also was followed by a significant open label extension component. And those patients who elected to stay with either active treatment or placebo, who were then changed over to open label, were followed for, and are still being followed actually. But in that group, in comparing the people who were initially on the AMX0035 to those who were on placebo, there also seems to be a significant survival difference. And so in that study, which was published in 2020, those patients had about a 6.5-month survival difference. The people who were on AMX0035 initially survived 6.5 months longer. Now, remember that this is about the weakest test of survival that you could get, because everybody after 6 months was placed on active treatment. So in reality, if these results are in fact true, they probably predict a greater survival advantage than what was initially seen. So this is a drug that's, there is a larger phase 3 trial now being initiated, and hopefully will be part of our armamentarium pretty soon. One last drug that I think both of us are excited about is a member of a class of agents called antisense oligonucleotides, which are short nucleic acid chains that directly match the RNA that produces the protein in genetic ALS that, when mutated, causes disease. And tofersen, which is an antisense oligonucleotide directed against RNA to produce the protein superoxide dismutase, has been studied in a phase 1 and now is being studied in a phase 2/3 trial. But data from the phase 1 trial was published again late in 2020 and showed some dramatic effects. James?
Yeah, I mean, I think in a general sense that it was a small number of participants whose data was published, but the SOD1 ALS, and particularly rapidly progressive forms of the mutation, cause really a predictably aggressive decline in the ALS-FRSR. And what we really saw is that participants had really a flattening of the curve that was pretty incontrovertible. And along with that, we saw reductions in neurofilament levels. And neurofilament is, we think, a marker of neuronal loss. Is not specific to ALS, certainly, and being explored in many, many neurological diseases. But we do see a pretty robust elevation in especially rapid progressors with ALS. So we have both biomarker and clinical evidence that in this one subpopulation that is, has a fairly predictable disease course, that we could see that curve changing. And I think it made us all incredibly excited to see the results of the phase 2/3 that's going on now.
Yeah, no, I agree. And I mean, the cautionary note is mostly that about 10% of ALS is inherited in a clearly autosomal dominant fashion. About 70% of those people have a gene that is identifiable, and only about 10 to 15 to 20% of patients with inherited ALS have the gene mutation in superoxide dismutase. Although I think it's very likely that this is going to be revolutionary for those people with that mutation. It's between 1% and 2% of everybody with ALS. So we still have a ton of work to do.
I would just interject to say that the tools that are being developed to do this, antisense oligonucleotides, parsing out the genetics of ALS, understanding genetic contributors to sporadic ALS, are really just going to, I think, herald a whole new way of approaching the disease, and it's incredibly exciting.
Yeah, I agree, and it's not just ALS. I mean, when I was training, genetic diseases were really thought to be the one kind of disease you could never fix. And it's turning out that in many ways we're better at altering the genetic code and genetic diseases than we are for sporadic neurodegenerative diseases, which is quite the contrast that as compared to when I sort of started work in this area. So we've talked about a number of agents that are moderately effective in treating ALS, and a couple more that hopefully will come online soon. And there are going to be many others as well. But although it's our hope, I think it's not necessarily the expectation that any new drug that's positive is going to be so dramatically effective that it will be the cure for ALS. And so in that light, I think it's important to talk about how we might use multiple drugs that all have modest effects. James, what do you think about that?
Well, I think one of the big differences between the drugs that we've talked about for ALS and a field like multiple sclerosis, for example, is that in multiple sclerosis, most of the drugs are targeting the same pathway, which is in inflammation. And so combination therapies have to be done really carefully because they have an additive effect on the same pathway. We really are talking about drugs here that are attacking different pathways in the pathology of ALS. And so I think really combining these therapies is standard in the way that we're using them now. And I think will continue to be. I think we, as you said, we may not have one single home run drug in the immediate future. Maybe we will, and we hope we will. But even if we don't, the combination of these therapies, we think, can get us further than any one of them alone.
In that regard, the analogy might be, rather than multiple sclerosis, it might be in the way that cancer is more and more effectively treated with really intelligent combinations, different drugs targeting different mechanisms, working synergistically together. And I think I agree with you. I think that's more of a real hope for patients with this disease than the search for the elusive complete treatment, which we may find, but we may not.
And important to keep in mind that in the Edaravone study, as well as in the AMX 0035 study, participants were on riluzole, and in some cases in the AMX 0035 study on riluzole and Edaravone. And so the benefit that was found was on top of those other therapies.
I agree. And so in many ways, this sort of combination approach is already happening. I think it would be important to really include in any discussion of treatment of ALS all the things that we actually can do to help ALS patients both feel better and function better. And this is also, I think, a change from 20 years ago. An ALS clinic is an amazingly interventional place. We do a ton of things, both medication-wise and in terms of devices and therapies. And so one sort of exciting drug that also may have a disease-altering effect as well is a combination of dextromethorphan, which is the active ingredient in many cough syrups, and quinidine. This has been marketed in a proprietary way in a specific combination to address a symptom called emotional lability or pseudobulbar affect, where patients don't necessarily feel incredibly sad or happy, but will laugh or cry uncontrollably. And Nuedexta, or this combination of dextromethorphan and quinidine, is amazingly effective at treating this particular symptom. In the trial that actually showed that, there was also a perception on the part of the investigators and patients that those patients on the active treatment who had bulbar symptoms, that is, difficulties in speech and swallowing, also sometimes noticed that that was improved. And so a second study was done to address that question. James, you want to summarize that?
Yeah. So in that study, the main goal was to see whether there was a subjective difference in rating between bulbar symptoms, that is dysarthria primarily, in people taking placebo and people taking dextromethorphan and quinidine. And the answer was on subjective scales that, and it was a crossover design study, when people were on dextromethorphan quinidine, they had lower subjective ratings of dysarthria. And there was embedded in that study, there was also a capture of recordings so that we could use quantitative motor speech analysis to analyze those recordings. And the quantitative motor speech analysis really backed up what the subjective rating showed, which is that people who were using dextromethorphan quinidine had less dysarthria, more mild dysarthria.
And just in my use of this drug, I see the same thing, and many of my patients do. But that's certainly not the only set of symptoms that ALS patients need treatment for. Those patients with bulbar symptoms will have progressive trouble swallowing and ultimately can die because of calorie restriction unless we do something about that. And we use feeding tubes quite extensively in patients who feel that that's in their interest. And both in terms of quality of life and probably life extension, that's a significant intervention. Other kinds of devices revolve around people's progressive loss of respiratory function, which is a hallmark of ALS, and most patients will ultimately die a respiratory death. But various forms of non-invasive ventilation can truly and dramatically increase patients' quality of life and also longevity. So those are two kinds of devices that really change the course of ALS for many people. Other symptoms are also treatable, and I'm interested to hear what kinds of things you find especially useful.
Well, I think being able to manage sialorrhea is I think a big part of symptom management for people who have bulbar involvement with the disease. And so we have a variety of medications that we can use that help us manage them, from scopolamine patches to atropine drops to glycopyrrolate, all to help reduce secretions, but also guaifenesin to thin secretions that are thicker and help people manage them that way. I think those are really important. We also, another device that we use, actually two more devices that we use to kind of help with secretion management and respiratory, are cough assist machines that help people clear things from the pharynx or the back of the throat. 3 machines. Suction can help them kind of get that out. And then sometimes if secretions are really thick, we can just use saline nebulizer to kind of humidify and break things up and make that more manageable. The tagline for ALS is that it's a painless progressive weakness, and it certainly is. That is the biology of the disease. It is true, though, when people have more disease and are more immobile, that they can have various kinds of pain. And so physical therapy is, I think, really important for preventing things like frozen shoulder, finding sleep positions that are comfortable, and sort of preventing pain before it starts. Obviously, we can treat pain, but if we can prevent it, that's even better. And then muscle cramping is something that most patients experience, and I think some experience in a way that is really, really bothersome. And mexiletine has been shown in a number of trials now to be a very effective way to manage cramping in people with ALS.
I think we're reaching the end of our allotted time, but I just want to mention a couple of others. I mean, so not everybody with ALS, despite the gravity of the diagnosis, is depressed, but some people are. And so use of antidepressants is, I think, quite effective. Many patients with ALS are anxious and have trouble sleeping, and we can treat that effectively. I think in general, it's just really important to remember that ALS patients present to physicians with symptoms and complaints that, even though the underlying disease it may not be dramatically remediable, the symptoms are quite accessible to us in terms of treatment, and it really does make a meaningful difference in the way people live their lives. So I think in a fairly short period of time, we've talked about a lot of treatment options and hopefully some exciting options for the future as well. I think that the next few years in ALS research and then treatment, I think, are going to be dramatically different. So I think at this point, we should end the discussion. And thanks a lot, James. It was a great talking with you.
Yeah, it was really wonderful to talk. I'll put in one final word, which is that, I think ALS is an area that is just burgeoning with clinical trials, and that's often something that people with ALS want to participate in. And I think we're making more and more robust ways for many, many people with ALS across the country to be able to participate in trials. It's been a lot of fun talking, Jeremy. Thanks so much.
And thank you, everybody.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/ALS. Thank you for joining us today.